Hello, my name is Dr. Padraig O'Sullivan. I'm a neurologist in the O'Donnell Brain Institute at UT Southwestern. In this video, I aim to explain the neurologic condition called normal pressure hydrocephalus, or NPH. Hydrocephalus can be translated to water in the head, literally the clear fluid that you might recognize as spinal fluid or cerebrospinal fluid or CSF. There is more of it than usual in the head. As a starting point of our explanation, this is what a brain scan looks like in a healthy young person. The dark areas in the scan are cerebral ventricles, which are cavities containing CSF. Here, they are healthy and narrow. With nice small ventricles like this, there's plenty of space in the head for brain tissue. The possibility of NPH diagnosis usually arises when a brain scan is done on an elderly person presenting with changes in walking and balance and slow thinking processes. And the scan shows enlarged cerebral ventricles. There is less space in the skull for brain matter, and this can result in progressive neurologic symptoms. To understand this, let's review the circulation of CSF in the healthy situation. This is a three-dimensional view of the ventricles shown here in green. Now looking at a side view, CSF is generated by specialized blood vessels in the cerebral ventricles called choroid plexus. Approximately 20 mils are produced each hour. Fresh CSF passes through a narrow passage or aqueduct and passes to the surface of the brain and the spinal cord and is now in what we call the subarachnoid spaces. From here, it returns to the bloodstream through the arachnoid villus. The average adult has approximately 250 mils of CSF, which is approximately 1 cupful. CSF has some important functions that require well-regulated circulation. For example, it provides physical protection of the brain, which is cushioned all around to absorb impact, and it removes waste products from the brain. A problem arises when the arachnoid villi get blocked or partially blocked, making it harder for CSF to exit. It backs up the system and the ventricles enlarge. What might cause partial obstruction of the arachnoid villi? Well, a minority of people with NPH come in with a known past history of a brain infection or inflammation or bleed, and we sometimes say that their NPH is secondary to the prior diagnosed illness. But most people we evaluate have never been diagnosed with a previous explanatory brain disease. And the term idiopathic is sometimes used to say the cause is unknown. I'm going to speculate here on possible causes in these cases. An undiagnosed spinal meningitis is one possibility. Like all infections, there is a range of clinical severity. Obviously, a severe case, a person is very unwell and is diagnosed and hopefully treated. And if they come with that history later, we say it is secondary. But minor cases of meningitis are probably more common than we imagine, with just some nausea and headache. And in some cases, the meningeal inflammation might cause enough fibrosis or scarring of the arachnoid villi to start the ball rolling for NPH. Or another explanation could be small subarachnoid bleeds. Once again, major bleeds are medical emergencies, but small ones might be unrecognized and cause partial blockage that shows up down the line as NPH. Repeated head trauma might damage the arachnoid villi. And I am intrigued at the possibility that pressure elevation in the veins just inside the skull, due, for example, to narrowing or back pressure, that this could reduce the pressure differential for CSF to return to the blood and result in retention of CSF. Listed here are possible causes of NPH other than partial blockage of arachnoid villi just discussed. The aqueduct may become narrowed or kinked in some people. The cilia, or paddles which line the ventricles and propel CSF along, these can malfunction. And we know there are mutations in the genes that code for motile components of the cilia. And in fact, such mutations are found in more than 10% of people with NPH. And this indicates that when the cilia are not moving the CSF along, it can remain static and enlarge the ventricles. Finally, let's talk about arterial blood flow, another relevant fluid. Arterial pulsations move blood through the body, and with each heartbeat, roughly 10 mils of fresh blood enters the brain tissue, and the same volume leaves via veins. Propulsion of blood is initially by cardiac contraction, causing a pressure waves, with arteries expanding, followed by narrowing of the elastic arteries, like what you feel in pulses in your arm. As we measure CSF pressure, we can detect the rise and the fall of CSF pressure with each heartbeat, usually 1 or 2 millimeters of mercury. In some people, the cerebral pulsation pressure waves are high, 5 or 10 millimeters of mercury. I think that hardening of the arteries, causing high arterial systolic pressure and low diastolic pressure, could contribute to this. And I think it could be a real problem with arteries, in this case, transmitting excessive force onto the brain tissue with each heartbeat and wearing down the aging neurons. I think there could be benefits to dampening this water hammer effect on NPH, for example, with blood pressure medication, though so far this is not researched. So hydrocephalus means excess fluid in the brain or in the head. What about the rest of the title, normal pressure? What does that signify? Well, we can measure CSF pressure with a pressure gauge, and in health, it is usually 5 to 20 millimeters of mercury. There are hydrocephalus conditions in which the CSF pressure is considerably higher than this, and those are usually medical emergencies. And then there is the form of hydrocephalus we are talking about here, which is not a medical emergency, hence the name, and the pressure when we measure the pressure in people with normal pressure hydrocephalus is usually in the normal range. The condition is more gradual. The pressure is in a normal range for most of the time, but when we monitor it, sometimes we find waves of higher pressure. If there is partial obstruction of CSF outflow, or some of the other problems we discussed above, CSF volume is increased and the brain volume is reduced. This is a slowly developing situation causing gradual deterioration in brain function. The symptoms are classically called Hakim's triad, after the doctor who first studied this about 70 years ago. The triad, or 3 symptoms, are changes in walking, changes in thinking, and changes in bladder control. This may be because the brain pathways for these functions track close to the ventricles and are thus most affected by mechanical strain as the ventricles enlarge. The concern is that if it is left untreated, NPH tends to worsen over the course of a few years to ultimately cause dementia and debility, with inability to walk and total incontinence. How common is NPH? Well, depending on how you define it, for example, possible NPH could be diagnosed in almost 3% of people over age 60, but proven NPH is only about 1/10 of these. Estimated 55 new cases per year in a population of 1 million. So the entire metroplex may have a few hundred new cases each year. The average age of diagnosis is about 75. It is uncommon in the 50s and rarely in younger people than that. While there are genetic mutations in cilia, we don't find people with diagnosed family histories very commonly. Maybe previous generations didn't live long enough or had other illnesses or had NPH and was not recognized as such. There is little data on how the condition progresses if not treated. We think gait and cognition are likely to worsen to disability over the course of a few years, but few patients have been followed without treatment after diagnosis in order to have any precision on that. 70 years ago, Dr. Hakim taught us about shunt surgery for NPH, that patients stabilize after the surgery and their symptoms sometimes reverse. A shunt is a small tube that runs from the cerebral ventricles down to the abdomen under the skin, with a valve to allow one-way flow, removing CSF from the brain when it rises above a certain point. The technology of these valves has changed over the decades. The ideal valve will keep the volume and pressure of the CSF stable, aiming to prevent further injury of the brain and allow recovery. Shunts are the only effective treatment available today for most NPH patients. 3 out of 4 patients experience improvement or seem to stop declining. Of the triad, gait loss is the most responsive to shunt, more so than cognition and bladder control. The people who show benefits after surgery can sustain these benefits long-term, but in others, the symptoms can start progressing again. In these cases, we check the shunt and the pressures, and sometimes we don't have a good solution for that situation. We have to consider the possibility that the brain injury processes that have been put in motion and shunting, by the time we do it, can't consistently reverse the condition. We should also discuss some downsides. And there is an amalgamation of multiple reports showing patients for at least a few years after surgery. Overall, approximately 16% need to be redone due to blockage or breakage or other malfunctions. 15 to 20% of people get some bleeding in the brain on the surface of the brain. Sometimes these are small bleeds and only seen on a scan and not causing any problems. But surgery, sometimes they're causing significant problems, and surgery is necessary to remove the bleed. 2% of shunts get infected, which can mean antibiotics or even removal of the shunt, and then we are back to square one. For a sense of the scale of it, about 1,000 shunts get implanted in the US each year for NPH. Apart from the shunt, other elements of care are to manage the blood pressure. Physical therapy and rehabilitation can leverage the benefits of shunt to recover gait and mobility. A walker or cane or wheelchair, if that's the safest way to get around. Aerobic exercise is good for the muscles and bones and endurance and resilience and blood flow and general health. And diet and good sleep-wake cycle are also important. We sometimes use dopamine medication in a subgroup of patients, depending on how they move. And we sometimes use bladder medications. We don't have good evidence that memory medications or supplements are effective in NPH, though there has not been much research on that. Now I want to talk a little about the difficulty of diagnosing NPH. NPH is usually first considered as the diagnosis when a patient presents with one or more gait changes, cognitive decline, or urinary changes, and a brain scan shows enlarged ventricles. The dilemma in these cases is whether the disease process going on is fluid backup problem, as I just described for NPH, or if it is a cerebral degeneration. This is because cerebral degenerations, including Alzheimer's and Parkinson's disease, can also cause gait and cognitive and urinary problems that look kind of like NPH. And their brain scans can also show enlarged ventricles, in this case due to shrinkage or atrophy of the brain and filling up the space with fluid. So we need to know whether the appearance of enlarged ventricles in the person presenting with gait and cognitive and bladder symptoms is due to NPH on the one hand, or due to cerebral neurodegeneration on the other hand, because the management is very different. The fluid problem of NPH could be helped by a shunt, but we wouldn't expect a cerebral degeneration to be helped by a shunt. You sometimes hear doctors saying there is ventricular enlargement out of proportion to cortical atrophy, compared to other cases in which they say there is proportionate ventricular enlargement and cortical atrophy. In this case, on the left is a scan consistent with normal pressure hydrocephalus. The ventricles are enlarged and the surface of the brain is kind of packed in. On the right side of the screen, there is similar degree of ventricular enlargements, but all the surface of the brain is shrunken away due to cerebral degeneration rather than fluid backup. But there's a lot of uncertainty. Expert doctors try to put together the history, including the time frame and the type of symptoms and the brain scan, and give their opinion if the problem is due to fluid or degeneration. Quite often, after taking the history and exam and looking at this brain scan, even experts are unsure. So diagnosis at that stage is provisional. We may say possibly NPH, or this is consistent with NPH, but we're not sure. The next step is usually further testing, something we'll talk about in a companion video. While we have some knowledge about NPH disease process, clearly we need to understand more about this and how to accurately and easily diagnose NPH and how best to treat. The Hydrocephalus Association did a nice job of taking input from stakeholders, primarily patients and caregivers, to identify community research priorities. These are developing better therapies, reducing the burden of current therapies, better screening and diagnosis, improving quality of life and access to care. For more on these community research priorities and for additional information about NPH and support resources, the Hydrocephalus Association is a helpful website. In the NPH program in the O'Donnell Brain Institute, we wish to provide state-of-the-art care and treatment of NPH. We implement best practice processes and then evaluate the outcomes for continuous feedback and improvement. In this way, we hope to contribute to advancing the treatment of NPH, and we'll welcome you to be a part of this.